amazing program that it is now. And he has offices all over Chicagoland.
When does it start in Advocate, specialized limb preservations, like 10 years ago or what?
2014, yeah, 10 years ago.
2014.
Yes, yes.
Yeah, and he has offices on Cicero Avenue in Oakland, Southwest Highway in Paris Heights, Martin Luther King Drive in Chicago, 93rd Street in Chicago, and Cicero Avenue again in Oakland. He's board certified in American Board of Internal Medicine, Interventional Cardiology, American Board of Internal Medicine, Cardiovascular Disease. His fellowships were obtained at William Beaumont Hospital, Interventional Cardiology, East Carolina University in Cardiology, and he performed his residencies at East Carolina University in Internal Medicine. And his medical education was at University of Arkansas College of Medicine. And he works out of all Advocate hospitals in the Southland, Christ, South Sun, and Trinity.
Thank you so much. I appreciate it. So where's the mic? Would be just this here, this whole thing. Okay, so I'll stand over here just so the mic will recognize me. Thank you so much for the kind introduction. My name is Jaafer Golzar, as previously mentioned. So I'm an interventional cardiologist. So you'd say, well, you're a cardiologist. Well, why are you doing vascular work? So all cardiologists are cardiovascular physicians. It's just most cardiologists focus on the heart, and I've dedicated my career in focusing on the pipes that supply blood to the rest of the body. So today we're going to be talking about peripheral arterial disease. And we're kind of, it's why this is an important topic, you'll start to understand. But looking at some of the epidemiology, you'll see that peripheral arterial disease is more prevalent than coronary artery disease, than cancer, stroke, HIV. So it is one of the most prevalent diseases globally as well as nationally. We estimated about 20 million people have peripheral arterial disease with a significant annual economic burden. And the peripheral arterial disease is growing, the incidence is growing, and we continue to undertreat this disease. So what
PAD stands for?
We're about to talk about it. So peripheral arterial disease, PAD is peripheral arterial disease. And I'll show you some slides and talk to you about what it means, but we're going to go back to mini medical school. Let's start from scratch. So how does the cardiovascular system work? So the heart is your pump. So the heart pumps blood. Now you have to circulate that blood to the rest of the body. And those pipes that circulate blood to the rest of the body are called arteries. So imagine just like the pipes in your house, you have pipes in your body. And so as soon as your heart pumps blood, the first pipe goes to your right arm, then it goes to your brain, then it goes to your left arm, then it comes down, supplies blood flow to the kidneys, and then it keeps going down, and right around your belly button, there's a fork in the road. Half the blood goes to the right, half the blood goes to the left, and the blood flow goes all the way down into your tippy toes, and then comes all the way back up to your heart through the veins. So when we talk about peripheral arterial disease, again, think about the pipes in your house. So over decades, the pipes in your house can get clogged with all the gunk and all the stuff that kind of builds up over time. Well, the same thing happens in the pipes in your body. So over decades, those pipes can get clogged. Now, usually the pipes in your body, they get clogged with cholesterol. And so this is what happens, and we'll talk about what causes it, but this process starts in your 20s. So the same blood vessels that supply blood flow to the heart, supply blood flow to the legs, supply blood flow to the brain. So if you have blockages in the blood flow to the heart, then you likely have blockages everywhere in your body. So that's what we talk about when we talk about peripheral arterial disease. Coronary artery disease means blood vessels to the heart. Peripheral arterial disease means blood vessels to the rest of the body. So I've dedicated my career in opening up blood vessels outside of heart that supplies blood flow to the rest of your body. So what causes peripheral arterial disease? These are the things that we know about. There may be more things that we haven't even discovered yet, but these are the things that we know about. Smoking, that's usually the number one thing, but you can have peripheral arterial disease even if you've never been a smoker. Diabetes, advanced age over 65, but we see in smokers, poor circulation or peripheral arterial disease usually starts in your 50s. High blood pressure, family history of poor circulation or peripheral arterial disease, and high cholesterol. And essentially, when we talk about these blockages forming, it's basically cholesterol that that clogs up the blood vessels. So some type of damage happens to the blood vessels, usually because of high blood pressure or diabetes or smoking, and then cholesterol starts to absorb into those blood vessels. So what are the symptoms? How do you know if you have peripheral arterial disease? Well, 40% of patients don't have any symptoms. You don't feel it at all. You don't even know if you have it. So that is, I'm going to kind of go through the gamut of what happens when you have peripheral arterial disease. 40% of patients don't even know they have it. However, the initial symptoms of poor circulation or peripheral arterial disease is usually tightness, heaviness, squeezing in the legs. When you walk, that goes away when you stop walking. So imagine just like your car needs gas, and when you want to accelerate your car, you push on the gas pedal, gas goes into your engine, and you're able to go forward. Same thing happens when your legs. Your muscles in your legs are the engines of your body, and so when you need blood flow, if you have blockages and you can't get it, you start to have pain, and that's your body telling you there's something going on, there's something wrong. Next step is critical limb ischemia. So this is sort of what I call the heart attack of the legs. So just like you can have a heart attack, and that usually means that the blood flow to the heart is significantly compromised, the same way you could have a leg attack, which means that the blood flow to your legs are significantly compromised such that you can lose your legs. And this is what we call critical limb ischemia or critical limb threatening ischemia. And this is where we start to get the rubber hits the road. And this is what we're going to really start talking about today, because this is what leads to amputation. And so usually what you'll see is you'll see that foot looks really angry. So it's going to be red. It's going to be painful. You may start to see open sores and ulcers on the toes or on the heel. And then it can progress to gangrene, which can lead to amputation. And I'm glad you guys are not eating dinner right now, but these are some of the pictures. These are some of our patients that you see. And these are all patients that we have saved. These are all patients that were recommended amputation and that we have saved. So this is what gangrene looks like. It's black. Obviously, it's not normal, right? So when you look at this, you look at your foot, because patients ask me, what does gangrene look like? It's not going to look normal. When you look down at your foot and you see something black like that, you're like, okay, there's something wrong here. When you see open sores and ulcers like that, there's something wrong. So that's what gangrene looks like. How do you diagnose it? So the easiest way is we have non-invasive imaging. So ultrasound is one of the simplest ways. So just like you can get an ultrasound of a baby in utero, you can get an ultrasound of anything, of your heart, of your blood vessels to the brain, of the blood vessels to the legs. It's non-invasive. It's easy to do right in the office. Then we can also get CAT scans, CT scans or MRI that shows us the actual blood vessels, and we can evaluate where the blockage is. And then the gold standard is an angiogram. So you've probably heard about angiograms that people have to look at the blood vessels in the heart. Well, we use the same technology, and this is where I come in, is we use the same technologies that we use to open up blockages in the heart. We use those technologies to open up blockages in the legs. And so you can see here, it is an invasive procedure, but it's minimally invasive. Tiny little incision in the groin, about 2 millimeter incision. Then under X-ray, with the dye, we're able to take pictures of the blood vessels. And the good thing about it is at the same time, we can open the blockages. So let's talk about the medical treatment and the non-invasive treatment first, before we get into the interventional treatment of poor circulation. So medical therapy is controlling all the risk factors that we talk about. If you have high blood pressure, controlling the blood pressure. If you have cholesterol, put you on cholesterol medicine, making sure you stop smoking or cut down smoking as much as possible. Exercise, foot care, making sure that you have a good podiatrist that follows your feet, because if you get a sore or ulcer, then you want to be referred soon. And then there are two ways to open or restore the blood flow to the foot. There's an endovascular approach. Endovascular, that means within the blood vessel. That's what I do. So I open up your own blood vessel, which instead of doing bypass surgery. So there are some of my surgical colleagues that do surgical bypass. I've dedicated my career. This is all I do all day, every day, is opening up people's blood vessels. So I don't do anything else. So, there's three different fields that treat this. So there's cardiologists like myself. So we have the wire and catheter skills, and this is what we do. But a lot of cardiologists do, 80% heart, 20% peripherals. I do 95% peripherals, 5% heart. Vascular surgeons, again, now they split their time. They do a lot of bypass surgery, and they do some of this. So the amount of experience still that they're good at what they do, but it's different. And then interventional radiologists that do a lot of other things as well. So we all have our gifts, and this is sort of one of the things that I've really committed myself to over the past couple of decades. So there's a lot of different things that we can do, but essentially when we think about endovascular, we're opening up your own blood vessel. So we can do this by shaving out the plaque, by lasering out the plaque, by drilling out the plaque, by putting in balloons, by putting in stents, which are little pieces of mesh that open up the blood vessel. And so this is an example of what it would look like. So here you see on the right-hand side, you see a blood vessel that's 100% blocked. And here, I'll do it here. It's just so for our YouTube watchers. So here you can see 100% blocked blood vessel. And after we open up the blood vessel, we can restore the blood flow. Now, these are minimally invasive procedures. It's outpatient. You come in, get it done. Takes about an hour for me to do it, and you go home same day. Then our surgical colleagues, they do bypass surgery. So instead of opening up your own blood vessel, what they say is, you know what, forget about your own blood vessel. Let's just create a detour around the blood vessel. And so this is traditionally done with open surgery. So it's a real deal surgery, general anesthesia. You're in the, there are major incisions. You're in the hospital for several days. So it's not an inconsequential surgery, but it is another way to do it. Now, as we've had advancements in technology, there is a technology that we started here. We were the first in Illinois to do, called Detour, which is creating bypass without open incisions. So we actually have one of the highest number of volume in the country of this technology. It's called the Detour device. So it's doing bypass surgery without major cuts through the groin. So this animation is a demonstration of how it's done, and it's really incredible to see the advancements in technology of how we can do these procedures. So here you see the blockage in the blood vessel in the leg. And so what we do is with the same type of incision, tiny little incision in the groin, and then we use these specialized stents to create a bypass around the blockage. So the way we do it, we get access in the leg. We go down into the area of the blockage. So we get an access from the foot, access from top, and then we puncture out of the blood vessel to create our bypass. So we have there's a specific device called an endocross that punctures out of the blood vessels, out of the blood vessel into the vein, and from out of the artery into the vein, and then past the blockage. So we balloon that. This just kind of goes through the details of how it's done. And this procedure takes about an hour, hour and a half, instead of traditional bypass, which can take several hours, and we send the patient home several days. And then past the blockage, we pop back into the blood vessel. Here you can see that's how we do that in this animation. And then once you're through across that blockage, then we lay several stents, which are like these hollow pipes or hollow tubes. And similar to traditional bypass, we just bypass around or create a detour around the blockage instead of opening up your own blood vessel. Now, again, the advantage of this is minimally invasive outpatient procedure rather than being a full inpatient hospitalization for several days with major incisions and risk of wound infections, etc.
Creating a blockage in the vein when you do that?
Very good question. Very good question. So what you're doing is you want your vein to be 10 millimeters and your stent is 6 millimeters. So the stent only takes up half the volume of the vein. So this vein still has flow in it because it's only taking up half of the volume. And so there's only about a 1%, 1 to 2% risk of blood clot formation. And that's the main thing that you would be concerned about. And so that was seen in the initial clinical trials. And so we put you on some special medications to prevent blood clots from occurring. A very good question.
I have a question.
Yes, sir.
This might be done. but,
No.
Why can't cholesterol be extracted from a vein?
Okay, very good, from an artery. So why can't cholesterol be extracted? It can, and we do that. So when we talk about the endovascular approach, that's one of the things we do. So there are several ways to do it. We have a laser that we can go in and we can burn the cholesterol. We have a drill. So over time, sometimes what can happen when you have these blockages for decades, the soft cholesterol kind of imagine initially it looks like bulk butter, like flopping around in your bloodstream. But as it gets incorporated into the blood vessels after about a decade and longer, that cholesterol becomes hard and it becomes calcified like concrete. So in that case, we can't laser it. Laser won't do anything. Then we use a diamond tip drill. And that drills out. Almost imagine stalactites and stalagmites penetrating into that blood vessel. So you can drill that and pulverize that clot. That's another way. Then there's also another device called a turbo hawk or a silver hawk, which is almost like a ice cone shaver. You know, like the ice cream, not the ice cream, but the ice, snow cone shaver. So it basically goes in, it shaves the plaque, and it incorporates it into this little nose cone that we have. And then you actually can remove the cholesterol and you can see it. You can hold it in your hand. So yeah, there's all these different ways, but every time, so when we do an angiogram, when you get a significant amount of experience in doing these, when I look at an angiogram, I say, okay, this is how we should treat this one because of certain factors. So soft cholesterol, that removing the plaque is the best. If it's something like a lot of that calcium, then we should drill it out. If the patient's already had a stent or bypass surgery that's failed, then we would do it a detour device. So it's all, you have to understand all of these technologies so you don't just do the simple cases, you can do the extremely complex cases as well. Now, this is where it gets interesting. So I showed you all these amazing technologies, all of these technologies that we have, all these amazing techniques that we have. However, even though we have all of that, 25 to 33% of patients in America undergo primary amputation as the treatment of critical ischemia. So in America, if you go to a hospital and you show up with gangrene, 30% of time, they're going to cut off your leg. 50 to 70% of patients never have an angiogram, despite the fact that we know it decreases your risk of amputation by 90%. And these are appalling numbers. 60 to 70% of patients have no attempt to open the blockage prior to amputation. 60 to 70% of patients have no attempt to open up the blockage prior to an amputation. Now, when you have an amputation, it's not just loss of limb, it's actually loss of life. 50% of patients that have a below-the-knee amputation die within 5 years. 70% of patients that have an above-the-knee amputation die within 5 years. So you're not just subjecting that person to losing their leg and the socioeconomic challenges that come with it, and they lose their job, and their kids now have to stay at home and help them, and then they, they're in a nursing home and all of these other things, but you're sentencing them to death. So here's a great slide that shows out to 3 years, you're doubling the risk of death. Patients, even if you don't have amputation, patients with poor circulation have a high risk of death because they die of heart disease. But you're doubling the risk of death if you undergo amputation. Now, this is especially poignant in Chicago because there was a study that came out a couple of years ago from Cornell that showed that Chicago had the highest disparity in life expectancy between different zip codes. So you have a 30-year difference in your life expectancy depending on where you live in Chicago. That's significant. So if you live in Southside Chicago, African American community, you're gonna die 30 years younger than, and this is not, we're not talking about gunshot wounds and things like that. We're talking about social disparities as well. 30 years younger than if you live in Naperville. So it has the highest mortality gap between neighborhoods. Patients are dying 30 years earlier, and the #1 cause is cardiovascular disease. And amputation rates are significantly higher in Chicago. And I'm going to show you, I'm not just going to complain to you about all the problems. So I've heard these talks about disparities in healthcare and DE&I and all these things for over a decade, but all I ever hear is people complaining about it and how it's so bad and how everybody's dying. I'll show you what we did to change that. So interestingly, there was also a study that showed that African American people, despite their socioeconomic class, had a higher rate of amputation than their white counterparts. Doesn't matter how much money you make. If you're Black, you have a higher risk of amputation compared to white people. If you make less than 40,000 or greater than 40,000 compared to white people. So why are people getting amputations? This is this thing that's been perpetuated for generations of physicians because they keep teaching them the same thing. Cut off the leg, cut off the leg. It's too late, cut off the leg. It's too costly. These are the myths that I've heard over and over again. It's too costly to save the leg. The patient is too old. I've been a 102-year-old patient that was completely functional, lived by herself, cooked, cleaned, did all the loving her life, and she developed gangrene. Why would I sentence her to death? As soon as she gets an amputation, then her life is over. I could give her a few more years. Why not? There's no bypass targets. And so, traditionally, it would be the surgeons that dominated this field. So if you can't bypass something, you can't do it. But from an endovascular approach, you can open up your own blood vessels and restore blood flow. So endovascular has significant benefits in that way. Amputation is considered a conservative therapy. Let's be conservative with this patient. Let's just cut off the leg rather than opening up the blood vessel, which is considered invasive. And you know what? I hear this over and over. You know what? They're going to lose their legs anyway, so go ahead and cut off their leg and get it over with. So we never say that for someone that's coming in with a heart attack. They come into the ER and they say, you know what? He's fat. He's having a heart attack. Just let him die. Don't just, who cares? Just let him die, right? Because he's going to die anyway because he's fat. No, we don't say that. So why do we say that about people's leg? And it's not just over when you cut off the leg, because then these patients are subjected to, major complications and psychological issues and socioeconomical issues. So the other thing is people think is that, once you cut off the leg, then you just get a prosthesis and you'll be fine. And, let's see what happens to these patients after their leg gets cut off. So with limb preservation, 2/3 of patients go home. With amputation, 18 to 20% of patients are discharged home. The rest go to nursing homes. With limb preservation, less than 20% of patients will go to a nursing home. After an amputation, 70% and greater will go to a nursing home or rehab facility. And this is what increases the cost as well. And this is the kicker right here. This is the most important part of this slide. With limb preservation, at 2 years, 80% of patients are still walking and 90% of patients are living independently. Whereas with amputation, 80% of patients will never walk again. They'll end up in a wheelchair and they'll never walk again. They won't use their prosthesis because most of these patients are old and prostheses are very hard. So how do we promote more aggressive treatment of critical limb ischemia? We have to change the culture of amputation. And this is what we have. It's going to take generations to do this. One heart, one mind at a time, one patient at a time. And so I speak around the world about limb preservation. I've been to Asia, I've been to the Middle East, I've been to South America, Central America, all throughout the US, talking about limb preservation and how we've done it. Physician education is important. We have to teach physicians how to do these new procedures and new techniques. We have to teach them that they have to change the culture of amputation. And one of the reasons that I'm here today is patient education, right? This is probably one of the most, and this is what we're really working on now, is patient education. Because what happens is when a physician tells you, you know what, you're going to need an amputation, you think that your physician is right. And you say, okay, I guess I need an amputation. But that's not true.
A question,
Yeah,
you focus on the legs or the feet. What about the arms?
arms don't develop poor circulation.
Say it again,
Arms don't develop poor circulation.
and that's just because of the length of.
We don't know. We don't know about the difference in pathology, why that happens. We don't know why patients, the only patients that we see that develop poor circulation in the arm, very rare. Usually those patients on dialysis. But again, it's very, very rare. I've probably seen it twice in my career.
So it's
It's
like
always in the legs.
100% is always with the legs and the feet.
Legs, feet, and the blood vessels to the brain, carotids, right? That's how you have a stroke, or the blood vessels to the kidneys, or the blood vessel to the stomach. I would say 90%, I would say 80% is blood vessels to the legs, outside of the heart. 80% is blood vessels to the legs. 15% is blood vessels to the brain. And then the rest is like your stomach and kidneys.
Now, is that just because at the extremities, the arteries are so much smaller?
No, we don't know why. No, because they're kind of small in the kidneys. They're small, you know, they get small in the arms, like you were mentioned, but we don't understand. We don't know why that is. But that's where we see it mostly, in the legs. So we talk about patient education. So we need to educate our patients. And this is the pact that I have with my patients. I say, you know, because if I see a patient in clinic that has gangrene about to lose their leg, I might not just admit them immediately. I'll say, you know, I'll bring you back in a couple of weeks. We'll get you set up for outpatient procedure. But in the interim, if they end up going to the hospital, I make a pact with them. I say, you know what, if you accidentally have to go to the hospital, they're going to see your leg and they're going to say, you need an amputation. And your response will be, no, I don't, call Dr. Golzar. And then they're going to say, we don't have time to call Dr. Golzar. This is a medical emergency. You're going to die. And then you're going to say, no, I'm not, call Dr. Golzar. And this is the reason I have this discussion is this has happened over and over again. People get feared into cutting off their legs. And so just like if you have breast cancer or prostate cancer, you want to go to the best place in the country. Why is it that we allow people that are not doing the best work to work on us and cut off a limb? And so this is what we're trying to promote. And so, you know what, kind of what I always say, the cream rises to the top. Once you start to see, like, you know, I'm leaving University of Chicago and I'm going to go to Advocate Christ because these guys are doing limb preservation work and University of Chicago isn't. And we get a lot of patients from Northwestern, University of Chicago, Rush. Locally, we get a lot, we get people nationally as well. And so what they do is then they have to elevate themselves. We gotta do a better job. We're at University of Chicago. Why are people leaving us and going to Advocate? Why are people leaving Northwestern and going to Advocate? So that forces other people to do better with limb preservation.
A question.
Yes,
So are you saying then that basically in the entire Chicago area, Advocate and yourself are providing the only option of this endovascular procedure that you talked about?
no, there's many people that do endovascular, but not all endovascular physicians are created equally. So they don't all do you can do little work. If you're a plumber, you can be a plumber that just fix, your kitchen pipes. Or you can be a pipe layer that can do your entire house and do it at a different level than a regular plumber. So you gotta find the right plumber. So there's a lot of people, kind of what I say, there's a lot of people that are dabblers, right? They do a little bit, because they do a lot of heart work and they do some leg work, they do some bypass and they do a leg. You have to go to people that have dedicated their career to endovascular. So there's probably 4 people in all of Chicago that have the same skill level. Kumar Madasari out of Rush, myself, Jack Chamberlain, he's out of Hoffman Estates, and Paul Jones, he's out of I don't know where he is right now, but I would say we're sort of the top 4 in Chicago doing this kind of work. So, but I'll tell you what sets us apart from everybody in just a minute. So when we do this, the important thing is having a team approach. So we have podiatry, we have wound care, nurses, primary care physicians. So we dominate Southside Chicago. It's so all of the podiatrists, they come to us, all of the wound care physicians, they send us patients. And I'll tell you sort of how I started back in 2009. When I started, I went to my first podiatrist that I went to. Her name was John Dell Jenkins in Southside Chicago, African American community there. She runs an incredible practice. She's still there. And I went and I was introducing myself and I said, hey, this is my card. My name is Jaafer Golzar. This is what I do. And she said, oh, you know what? We already work with a team of vascular people. I said, you know what? Don't send me any of your patients except the ones that have been recommended amputation. And let me show you what I can do. And so she sent me, she was like, well, as a matter of fact, I have 2 patients that have been recommended amputation. I said, let me show you what I can do. And we saved both of their legs. And that's how I made my reputation here. That's how I started. And I'll show you our numbers because I knew we had something very special, but we had to do the work to highlight this. So we created a limb preservation program. We were highlighted in 2018 as we documented how we reduced our amputation rates by implementing a limb preservation program. So the first limb preservation program in Chicago, we implemented multidisciplinary limb preservation program was in Southside Chicago at Advocate Trinity Hospital. So remember, Southside Chicago, African American community, it's all gonna come together now. Why this is all important. African American community, African Americans have 3 times higher amputation rate than white people. And so we did our limb preservation in the heart of Amputation City. Amputation right there in Chicago. Not only does Chicago have the highest gap in mortality of 30 years, but African Americans also have the highest amputation rate. And this is where we landed our limb preservation program. Our goals were to prevent amputations in patients with critical limb ischemia, endovascular first approach. So everybody got an angiogram. Remember, I told you 60 to 70% of patients will never have an angiogram prior to amputation. We made sure everybody had an angiogram. So everybody had an angiogram prior to, well, they didn't get amputation, but everybody had an angiogram, and we had to follow our outcomes. We can't just be Dr. Golzar said he's doing a good job, then we believe him. No, that's not how we did it. We actually followed our metrics. And, yes, sir.
What does the angiogram tell you or give you that the CAT scan or the other MRI that they do not?
Yeah, so the angiogram, so any kind of imaging. So when we say 60 to 70% of patients they never had an angiogram, it's because once you're there, so the angiogram is the gold standard. You actually put the catheter in and you take a shot. So the nice thing is you're already there and you're like, I see the blockage, might as well try to open it. You see what I'm saying? So once you have your devices in there, say, yeah, let's try it. Let's give it a shot. See if we can open the blockage. So the angiogram is the first step for actually opening up the blood vessel. And so we were highlighted in 2018. This is with Love Your Limbs, and they came in and did a video on our limb preservation program.
That's a nice ring.
We started about 5, 6 years ago when we saw that there was a disparate amount of patients in Southside Chicago that were still getting amputations, just like they are across the country. And we started this by initially changing the culture of our hospital. We did it initially by picking the right team. And it was like physicians like Dr. Gerson, Dr. Julie Taylor, Dr. Ali. We brought these guys in, we allowed them to see what we can do by saving limbs, and they understood, they were passionate about it as well. And because they saw these patients in their own clinic, they saw these patients that were getting amputations and how it affected them and how it affected their social life, their psychology. It's a big deal. And they had that passion from the beginning.
Because I'm a family physician, I see a lot of diabetics. And diabetes is probably the #1 risk factor for peripheral vascular disease, one of the major risk factors. So we often check diabetics, we check their feet, their pulses, we send them to foot doctors.
We usually see referrals from family doctors and from the vascular doctors every day. There's a high incidence of vascular problems on the south side of Chicago, and once it's seen and once it's identified, then we use our limb salvage program with our members to be able to get the patients into one of the offices quickly.
The typical interaction is that the primary care doctor and the podiatrist may identify a patient who's at risk for peripheral arterial disease. After that identification, those patients will typically end up in my office. Or if they're inpatients, I end up seeing them in the hospital. Once I've confirmed that they are at-risk patients, then we'll probably pursue diagnostic testing on those patients.
So our podiatrists and our primary care physicians are really the gatekeepers as an outpatient. So they see these patients that come into the office that have maybe a blue toe or gangrenous changes. And instead of sending these patients directly for amputation, what we did is we worked with them to send these patients for limb salvage.
If there are any signs and symptoms, we get them to the vascular doctor quickly and immediately. We have a system where it's A, B, and C. So when I call the vascular doctor or the cardiologist, I say this is an A patient, which means he needs to see him within a week. A B patient is in a couple of weeks. A C is the next appointment. And so we always kind of rank them in a triage manner to be able to get the most serious patients in as quick as possible.
We're diagnosing diabetes much earlier than we used to. We're diagnosing PAD much earlier than we used to. So all of these factors, I think, and then once we find a problem, we're referring them more quickly to get a definitive, treatment.
Since we've been doing limb salvage work, there definitely is an impact. And the impact is multifold. First of all, the patients who come in urgently or emergently, those patients still come in. And that's a consequence of a disease process that's been going on for them for decades already. The biggest impact we've seen has probably been in both the hospital and the clinic in terms of the number of patients we're seeing who are getting amputations. I haven't sent a patient to get an amputation in a long time.
So there's definitely a multi-factor, multidisciplinary approach to this problem. And I think we are on the road to helping to limit the amputations that are going on in our community.
What we want to do is spread this program to many other institutions around the country. Because it doesn't make sense if one hospital in Chicago is doing this, we want 100 hospitals across the nation doing this. And so using our example, understanding that this is possible and having the passion and the understanding and know-how to say, you know, we can do this in our hospital, be it Chicago, be it Little Rock, Arkansas, be it Austin, Texas, wherever it is, use what we've learned in our knowledge and our understanding of helping these patients and bringing it to their institutions. I think that's the most beneficial thing that can happen.
So what did we do? We enrolled these patients, they came into the hospital, we opened up the blood vessel, we'll work with podiatry or wound care. We work with them to help with dietitians and smoking cessation consultation. We followed these patients very closely and we tracked the outcomes. And so we tracked these outcomes for a year. We enroll, and remember, I told you before at the beginning of the talk that 25 to 33% of patients with critical limb ischemia get amputation as the primary treatment. We enrolled 126 patients over an 18-month period, and our amputation rate was 1.58%. So this is what you can do by having a multidisciplinary, high-end team of experts working on patients with critical limb ischemia. So why is there this massive gap? Why is there 33% of patients nationally, 19% to 33% nationally, and 1.58% in our hospital? First, you have to be committed. You have to have the passion. Limb salvage is not easy. It takes a commitment. It takes working with your wound care specialist. It's taking, sometimes they have to go back. You have to open up some more blood vessels. So it's hard work, but it's worth it. And this number has been sustained in 2022 when we were named the first National Center of Excellence in the country. Advocate Aurora Health pulled our numbers again, and our amputation rate at that time was 3.39%. Again, sub 5%, which is unprecedented nationally. And so now we've spread this work to Advocate Christ Medical Center, and I was given a task to spread this initiative throughout the Advocate Aurora system, throughout all of our hospitals. And it's a labor of love, and that's what we're doing throughout our system. So what should you do if you or a family member or a friend is faced with amputation? Ensure that you're seeing a limb preservation specialist. And this is probably the hardest part because you don't know. And so we're working right now as we speak with the Global PAD Society to establish a website that people, patients can go to. So they do have a website that they can go to and be referred to the right person, or just look up your physician. Look them up on the on the internet. See what they do. Do they have YouTube videos? Do they have what kind of expertise? Do they speak around the country? Do they have lectures around the country on limb preservation? Look up your physician. It's worth it to know who you're dealing with.
May I
Yes,
ask
sir.
a question? From what you have presented to now, I get the impression that the real problem, or the main problem, is inadequately informed or aware, let's say, primary care physicians who are taking a very traditional approach. And it seems therefore that the main objective or the task for someone like yourself is, instead of talking just to potential clients or patients, or whoever's here tonight, you have to make the rounds of basically all of the primary care or first level of contact with a patient, because those are the ones that either are aware of the potential that you have to offer, or else they are unaware of it.
Yes.
And they're the ones that are critical as far as steering the patient and having his problem dealt with in the best manner, right?
Yes.
So, I mean, you need a bunch of. We are not the correct audience for you.
You are actually, because as I mentioned, it's a three-pronged approach. Change the culture of amputation. And that is more a generational thing, that we're all of us physicians nationally that do this work are doing. Physician education, absolutely, but patient education, right? Because patients demand the best care. Now, and I'll tell you a story. So in 2022, when we were named this National Center of Excellence, there was one of the vice presidents of Johnson & Johnson gave a speech at a church in Chicago. Okay, and he was talking about, because Johnson & Johnson had played a big role in this National Center of Excellence, and they had really supported us with that. And so he was giving this speech, and he was talking about all the good things that Johnson & Johnson is doing, and they're doing things with OB and hypertension. And they said, there's this team down inside Chicago that are saving limbs, and they are unprecedented work that they've done. And so he gives this lecture at the church. Fast forward, 3 months later, there's a gentleman that goes to University of Chicago, and he's gonna get an amputation. So he calls his brother, and he says, "Brother, pray for me, because they're gonna cut off my leg tomorrow." Not tomorrow, he said, "They're gonna cut off my leg." So this brother goes to church, and he goes to the pastor, and he says, "Hey, pastor, could you please pray for my brother, because they're gonna cut off his leg?" And he said, "Wait, hold on just a second. I remember this lecture that I heard a couple of months ago with the vice president of Johnson & Johnson, and he said, so-and-so is doing some work down in Chicago. I have this guy's phone number. Let me call this vice president." He calls the vice president calls me at 9 p.m. at night. I call the patient. So you have to see, it was like 5 levels of separation to get this patient in. There may have been some divine intervention to get this patient in to see me to save his leg. I called him that night. I said, "Sign out of University of Chicago against medical advice. Tomorrow morning, come and see me at Trinity Hospital. We saved his leg." So it's a multi-pronged approach. If that pastor had not heard that lecture, and then this patient had not told that he would be an amputee now. And so it's also, remember, like I said, I remember a patient, we have another video here. We got a patient from Houston. He was an engineer. And they told him nothing you can do, you're gonna have to cut off your leg. He got online and he looked up new therapies for peripheral arterial disease. They told him in Houston, this is Houston, big city, Houston. They said, "Nothing we can do for you." He looked online, found us in Chicago, came here, opened up his circulation. So patients have to be concerned about their own health. And so they have to serve, if I have cancer, or if I have any other medical issue, I want to go to the best place. I'm not going to rely on my primary care physician where to go. I might want to go to Mayo Clinic. My primary care physician may say, go to, some, maybe Edwards Hospital. So I think it's all of those combined. Primary care physician, yes, but there's thousands of them. So we have to change hearts and minds. So you may remember this talk, you may go tell a friend, they may hear, one of their family members is about to get an amputation. And if we even save one leg, this is worth it.
Okay, my gut reaction is based upon the attendance here tonight.
Yeah.
The average individual, is either not interested or else even cannot even relate to the topic.
Yeah. Yeah.
And
Well, I just did this for advocates. So I give talks around the world. I give my lecture. You can look up my name on YouTube. You will find hundreds of videos on YouTube. I ran a vascular conference for a decade. 3-day conference. We did live cases, satellite transmission, live cases. So I do a lot of education.
okay, so there may
Spreading this word. Yeah, spreading the word. So if no attempt has ever been open to open up the blood vessel or was unsuccessful, get a second opinion. don't lead to amputation is first. Amputation should be the final option, not the first option. So in conclusion, I hope you, by this talk, were able to, I was able to relay this importance of the fact that critical limb ischemia has high mortality, high morbidity, despite advancement in treatment. Current outcomes may remain poor due to undertreatment. We have to overcome the myths of critical limb ischemia. We have developed a limb preservation program at Advocate Medical Center. And we have a team approach to treating critical limb ischemia, improving outcomes, saving limbs, saving lives. That's my talk for tonight.
So I have a question.
Yes.
What is the best time, in the disease process?
Yeah.
For arterial disease
Yeah.
to be referred to?
Yeah, so I sort of deal with the worst of the worst. So those patients that have critical limb ischemia. So those people that have gangrene, they're about to lose their leg. So that's where I can make the most difference.
Okay.
But you know, early in the stages of a diagnosis is probably upstream. Your primary care physician can make the biggest difference by controlling risk factors, high blood pressure, diabetes, being on a cholesterol medicine. From my standpoint, I like to save my clinic for those patients that are about to lose their leg, or that have pain in the legs when they walk, or that have been referred to bypass and they don't want to do bypass, so they want to do minimally invasive approach. But from my standpoint, I deal with the worst of the worst. Thank you for coming tonight.
So
Great question.
it's my pleasure to
Nice to meet you, sir.
know that you really got a mission.
Yes, sir.
And this is more than just a presentation on the terminology and the rest. How else can I say? You have got a real project on your hands, and I wish you the best.
Thank you, sir. Thank you.
Well, thinking, eye-opening, right? I happen to have an aunt who's one deceased, diabetic,
Yeah.
whose leg was amputated.
Yeah.
And they came along and they said, we're gonna have to amputate the second leg, and her life was over. You mentioned within 6 months or so. So I feel and I hear you very well, and okay, I don't wanna drag it out, but thank you very
Well,
much.
thank you so much for coming. I really appreciate it. It's really nice to meet you. Thanks for your help, man.
Yeah, of course.
Appreciate it. Thanks for your questions. Yeah.
So your aunt should have known about this program. Could have saved both their
Yeah.
legs, right?
Here you go.
Thank you
Here's
very
my
much.
card.
Thank
You're
you.
welcome.